Alright, so next up we are going to go over more disorders of the musculoskeletal system. So osteoporosis, this is a pretty common one that we think of. What happens in osteoporosis is that it's a disease of the bone density or mass, and it's going to be reduced overall. So loss of mineralized bone causes parts of the periosity of the bone to become weak and lost, and then they're at increased risk for fracture. It's more common in whites and Asian groups. Right? Healthy young women can gain bone mass up to 30 years of age. But what happens then is after we start aging, after 30, and especially after menopause and things, we tend to not gain any more bone mass. So physical activity, how much calcium we get, magnesium and vitamin D intake all play a role into it. The amount of body weight you carry, and even the amount and exposure to sex hormones at puberty can also play a role in your osteoporosis risk. So we don't really understand why osteoporosis happens. We know that there's an imbalance between the bone reabsorption, the transfer of calcium from bone into the blood, and at the rate of which it's formed, where we actually have more reabsorption than we have formation. And what happens is, what we see in people as they age, is the reabsorption is going to occur faster than the bone that we create. So overall then, over time you lose that bone, and the mass starts to decrease. So we lose the calcium, and we lose our stores of calcium, and then it's going to lead to our porous bones. Risk factors are going to be family history. Okay, on the left we're going to have our non-modifiable. Okay, so if we're Caucasian or Asian, especially if we're women and over the age of 50, we'd be at increased risk. The small, like a petite frame person who's thinner, would be at increased risk. If you're sedentary, so say you don't do a lot of exercise or weight-bearing activities, you're not going to build that bone mass, and you would have an increased risk. If you go through menopause earlier, and if you've never been pregnant before, you would be at increased risk. More modifiable things would be obesity, caffeine and alcohol intake, and smoking. E2H is alcohol, remember. Right, low estrogen levels and calcium levels can play a role. You could take supplements or hormone replacements if you needed to. And then it also can be a condition of hyperparathyroidism as well. So what we see then is that overall they may have bone pain and their bones can get deformed. They're more likely to get fractures because they have brittle and weak bones. In their back, you'll see vertebral collapse over time, meaning that those vertebrae are just going to start collapsing in on themselves and each other. Kyphosis, so that's where you see the curvature of the back up in the upper region. If you look to the right of the picture, that would be the evolution of kyphosis that can happen. They're going to get shorter over time, and they're at increased risk for fractures, and actually femur fractures would be the most severe. So here's a picture of somebody who has that kyphosis, that hump on the back. Another condition of our musculoskeletal system is scoliosis. So this is where we're going to have a curvature to our spine, but it's going to be in a lateral or to the side deviation. It may or may not involve a rotation or deformity of the vertebrae. You could just have a lateral deviation of the spine, meaning that it's not straight. Part of it is offset to the side. So they can have a sigmoid or an S-shaped curve to their spine. It is usually greater than 10 degrees off. It's classified, it can be caused with postural habits. So if you have poor posture, it can make a curvature spine. And it could be functional, meaning that it could have difficulty with our function and impair our ability for day-to-day activities. Structurally, it could be caused by genetic. Okay, it could happen with embryonic development. It could be a neuromuscular condition like cerebral palsy or poliomyelitis could cause it. Or it could just be idiopathic, meaning that we don't know a cause, and it does occur in even healthy children at times. So it's usually diagnosed between 10 and 15. Some of you may have had screening for it actually during sports physicals or routine health physicals during their grade school years. All right, it's usually found during our school screenings that we do. 2% of all of our adolescents have scoliosis. Mostly it's in girls. It can be diagnosed in infancy. Whenever it's in infancy, it's more common in boys. Risk factors for non-structural are going to include malnutrition, chronic fatigue, lack of exercise, poor posture, and if they have muscle spasms related to an injury. Risk factors for structural are, we do see cases within families, so there's a thought to be a genetic link. If they're exposed to teratogenic factors, so chemicals or agents that are damaging to them. Intrauterine position, so how the baby is positioned while the mother is pregnant within her uterus, and then neuromuscular diseases as well. Next is arthritis. Okay, arthritis would be where we have an inflammation of the joint. So arth means joint, itis means inflammation. This affects women twice as much as men. The most prevalent types are osteoarthritis, rheumatoid arthritis, and gout. So let's look at each of those. So osteoarthritis is where we're going to have a slowly progressive, inflammatory joint disorder. Usually affects your synovial joints. So there's joints that have the synovial sacs and fluids in them. You have a breakdown of the cartilage. So your joints become less elastic. Your body can't repair it, and it can't keep up with the damage. So then we end up with inflammation of the joint. Okay. The cartilage is going to become thinner in the area. The bone growth can then become displaced or irregular at the joints. You're going to have uneven distribution of the weight, which could cause the bones to actually rub together. So you may actually hear people complaining of their joints creaking, or you could hear them rubbing whenever they have osteoarthritis. And overall, as that builds up in their joints, they're going to have a decrease or reduction in their motion capabilities. Osteoarthritis, we don't have any one single cause. They think that it's associated with estrogen reduction at menopause. That's why women are at greater risk than men. Genetics, obesity, because you're putting more strain and weight on the joints, and then overuse of the joints, because we see it more often in people who play sports. Inflammation is not a characteristic, but it may be a secondary process because of that small pieces of cartilage that are in there and causing irritation. Pain happens later in the disease because of those bones rubbing together. So here's an image where you have that irregular proportion or weight distribution at the joint. You can see over here on the right where there's still a little bit of cartilage, but here it has eroded away in the osteoarthritis, so those bones are actually rubbing together. So the most common joints that become affected are your neck, the low back, the hips, the base of your thumbs, the ends of the fingers, knees, and even the base of the big toes. The joints, they can range from a mild discomfort to being significantly disabled, meaning that they don't have a lot of function at all. They can have pain. This is the most predominant sign, and usually it's what causes someone to go seek help because they're not able to manage their pain with over-the-counter medications. The pain's going to worsen whenever they use the joint. So in early stages, if they rest, that might get better and they would have pain relief. But as it progresses, even whenever they're resting, they're going to have joint pain. Stiffness can occur, so you might hear them complain of having trouble moving in the morning, where they wake up stiff and it's difficult for them to get going. Crepitation would be that grating sound that you hear when bone's rubbing on bone. And it usually affects joints asymmetrically, so meaning that it can affect one side and not necessarily the other. The most commonly affected joints would be the fingers, thumbs, hips, knees, toes, cervical and lumbar vertebrae. Usually the side of the most use that somebody has would be the first side affected. So say they might notice that they're having joint pain and trouble in their writing hand, in the fingers of their dominant hand. Or if they're a sports injury, they may be having trouble in the hip of their kicking leg if they play soccer or football or something. So what happens in osteoarthritis is they get into a cycle. So they have strain on their ligaments, and then the ligaments get weaker. They continue to use their joint, and then the joints start to have the bones rubbing against each other as those ligaments and that cartilage breaks down. You'll hear that crunching noise whenever the joints move because of those bones rubbing together. And then they're going to end up getting irritation and overgrowth in the area, and that's going to be the arthritis that you can see. So it's associated with joint stress with osteoarthritis. It can be congenital anomalies too, joint instability, particularly if it's related to a trauma, or we just might not know the cause and it could be idiopathic. The primary defect is the loss of articular cartilage that occurs. The symptoms you're going to see is pain and stiffness in one or more joints. They can have joint swelling and tenderness, and then they're going to have a decreased range of motion. We don't have a cure for it. Non-pharmacological things you can do, so non-medication wise, they can rest, they could do low impact exercises to keep the joints moving and help with their mobility. Hot and cold applications, protect the joints, decrease their weight to put less strain on them. And some people like complementary therapies like acupuncture, massage, yoga, things like that. We can give them medications or pharmacological agents to help support the therapies. So that would be Tylenol. They could give them capsaicin cream. So that's actually to help increase warmth and circulation to the area, or other topical agents. If they have progressive pain, they could take NSAIDs, but remember that NSAIDs have an increase on your bleeding time as well as increase your risk for gastric irritation. So we want to be careful about complications. Arthroplasty would be where they might go in and do a reconstruction or replacement of a joint. This can be to help relieve pain and increase the range of motion, correct any deformities that have occurred over time. It can be for patients who have osteoarthritis, rheumatoid arthritis, or congenital malformations or hip fractures. And this would be an image of somebody, or of a hip replacement that somebody had. So this is the hardware they use. They screw it in and attach it to our bones and our sockets. You can see the screws right there out of the top. And then the bone is attached, they drill this into the bone of the affected area, and they are able to stabilize it, and their healthy bone will fuse in there to help set and keep the joint replacement. Alright, so that is the second part. Whenever you start the next video, we'll start off with rheumatoid arthritis and finish out with that one.